Wabarakatuh, and welcome to today's CPC from Department of Internal Medicine, UKM. I'm Dr. Ruslinda, the chairperson for today's CPC, and we have 4 presenters. If you look from your left-hand side, Dr. Meenakshi, anak perempuan Alagappa, will be presenting on the case, and we have 3 discussants, Dr. Wan Rohas Rizan from Internal Medicine, Dr. Imree Azmi from Radiology Department, and Dr. Wan Shahira from the Pathology Department, but she will be represented by 2 MOs, namely Dr. Nurazan and also Dr. Raniza. So we have many people here, and the title given for today's CPC, The Cure for the Pain is in the Pain. Right? What kind of metaphor is that? But I think it's time for us to learn about this case. I'm sure it's going to be interesting. So without further ado, I would like to invite Dr. Meenakshi to the floor. Thank you.
Thank you, Prof. Ruslinda. A very good morning, everyone. We will start. I'll present the abstract first that was given to me. Our topic is actually the cure for the pain is in the pain. So this is the abstract that was given to me. A 38-year-old beautician with underlying thalassemia was... Okay, so this is the abstract. A 38-year-old beautician with underlying thalassemia was presented to HCTM with complaints of nausea and vomiting for 2 weeks. The symptoms associated with poor oral intake and frothy urine. A month ago, she presented to the GP for headache and was treated symptomatically. She also has history of hospitalization in other hospital for unresolving urinary tract infection with renal impairment. She was admitted for 17 days and discharged home with outpatient review. So based on this history that was actually given, the few questions that we would like to ask from here, just based on the history. So she is a 38-year-old beautician. So beautician, I think based on history, what other further things we want to ask? Does she consume any herbal supplements, any beauty products? And underlying thalassemia, what kind of thalassemia? Is it transfusion dependent? Any iron chelations required? Otherwise, any splenectomy done? Any complications of the thalassemia as such? And based on a presenting complaint itself, she had nausea, vomiting for 2 weeks, poor appetite with frothy urine. The vomiting severity, the content of the vomiting, and any other associated symptoms also got to be asked. And frothy urine, she had frothy urine at that time. The symptomatic treatment for the headache, what was the symptomatic treatment? We are unsure whether it's NSAIDs, traditional medications. And she also had a prolonged hospitalization for UTI and renal impairment. What was done during that hospitalization and when was it exactly also we need to know. The antibiotics given during that time, the duration, any stenting or drainage done and dialysis required during that time. So this is just based on the history that we have. So moving on examination, she was actually dehydrated with a blood pressure of... So further history, I would like to ask a few questions based on the history of presenting illness. Did she have any fever during this time? Any recurrent urinary tract infection? During that time, she had an unresolving urinary tract infection. But currently, I would like to know whether she's been having recurrent episodes of UTI. Otherwise, dysuria at this time, increased frequency of urination, reduced urine output. Why do we want to know this? Whether increased frequency of urination, dysuria, whether she has any urinary tract infection. Reduced urine output, whether she has oliguria, AKI, history of renal stone, whether that is causing her recurrent urinary tract infection, and approximate volume intake and losses. She has been vomiting. How is the fluid intake and replacement for that? Her severity of vomiting, as I said, the content we got to know. Any other associated symptoms? Prior upper respiratory tract infections such as any cough, runny nose, sore throat, hemoptysis. Why are we asking about hemoptysis? We want to know whether it's any lung related, any pulmonary hemorrhage, lower respiratory tract infections, skin infections, CTD related history, myalgia, arthralgia, cutaneous rashes, CTD related oral ulcers, mala rash, and then we would like to get past medical and also surgical history. Any thalassemia, the thalassemia, was it transfusion dependent? Iron chelation, any history of splenectomy done? History of diabetes, besides that, hypertension, cardiac or renal disease, childhood GN, autoimmune diseases, and the baseline renal function during the previous visit, and when, and any vasopressors or dialysis required at that time with antibiotic history, and any contrast imaging done for this patient. So this is just a history of presenting illness and the past medical and surgical history. Further history that we would also like to know is any family history of renal disease or hemodialysis, social history, what is the marital status of the patient, infective screening of her partner, high-risk behaviors or drug abuse, drug history, any intake of NSAIDs, penicillin, supplements, over-the-counter drugs or traditional medication. Yeah.
All right. Thanks, Dr. Meenakshi, for that kind of overview. And she already illustrated further history that you would like to know. I would like to welcome anybody from the floor to add on or ask any question to her.
Thank you. Thank you very much for the presentation, Dr. Mina. Just that, let's say she's very bad, hypotension in emergency department. She cannot give you all the history. Can you give me 5 differential diagnoses that you have to think about? She went to the emergency department alone, and that was the blood pressure. Give us 5 differential diagnoses that you are thinking based on the history and also physical examination and also investigation given to you.
Okay, sorry, I think just now I did not really present the physical examination findings. So just for everyone to know, on physical examination, she was dehydrated with a blood pressure of 99/60 and a heart rate of 99, temperature of 36.7. Lungs were clear. Her abdomen was soft, non-tender, no organomegaly or ascites. This is what we have on the basic examination. So the 5 differential at this point that I could have for this patient is, she probably has a septic shock secondary to urosepsis or a pyelonephritis. She could also have a probable she could have acute tubular necrosis secondary to the sepsis itself, or secondary to infection, secondary to the drugs that she was taken, and a probable acute interstitial nephritis, as she was given previous symptomatic treatment for her headache at that point of time. We are not sure what was the medication that was given. Besides that, she also has thalassemia. Thalassemia by itself can cause renal impairment, although it's quite rare. It can cause nephrolithiasis, causing her to have this urinary tract infection. That could also cause her to be having septic shock at this point of time. Yeah, that's all.
But all the differential diagnoses that you gave for the acute kidney injury, or maybe acute kidney or end stage, but her blood pressure was a bit lowish and she was vomiting, and we have to look at patient as a whole, not as a kidney, upper pole of the kidney. I'm the specialist of upper pole of the right kidney. Left pole, I pass it to Prof. Rosita. So I'm just making a joke. So when you look at this, a patient came to you, what is the differential diagnosis that can answer all? We know that hypotension or sepsis can cause acute kidney injury.
Could be could be a hypovolemic shock itself because of a vomiting. Could be could be sepsis. Could be a septic shock that is causing her blood pressure to be low.
But for thalassemia patient, let's say they are transfusion dependent.
Correct.
When they came in vomiting and cannot take all orally, and blood pressure was low, and what must you think of that actually will help you in managing the patient in the emergency department itself? Anybody? Is that something that important? Your emergency department, you check. And of course, acute kidney injury cannot tell you what will be the long-term complication of blood transfusion.
They can have hemosiderosis. They can have iron deposition in the kidneys, in the heart, cardiac deposition, liver deposition, pancreas. So that can cause cardiomyopathy, dilated ischemic cardiomyopathy.
And deposition to the pituitary, what will it cause?
Pituitary can cause
no hormone produced by the pituitary. So what we
yes, the anterior pituitary and the posterior pituitary. The deposition of iron in the pituitary is also there. That can also cause them to have
Okay. Basically, you have a pen hypopate, and that they can present like this.
All right, thank you very much, Prof. Halim. Any other questions from the floor? All right, so I would like to invite perhaps Dr. Wan Rohasrizan to answer all of her questions raised just now.
Thank you, Prof. Ruslinda. All right, Dr. Mina, I'm answering all the questions. She had no history of fever for this current presentation. She had no history of UTI symptoms during this presentation, and no history of renal stones. Because of the vomiting, she's vomited about 3 to 4 times in a day. She just can take less than a liter in a day, and there is no other GI symptoms related to it. No history of any respiratory symptoms, and no skin infection. She denied any CTD-related history, no malja, no arthralgia, no cutaneous rash. In regards to the thalassemia, she's not a transfusion dependent, and she was never been on any iron chelating agent. No history of surgical intervention in the past. No chronic illnesses was mentioned, and she denied any other autoimmune diseases as well. Back to the question number 3 and 4, I will go into it later. So she denied any chronic illnesses in the family, even so there is no other family members on hemodialysis. She's a divorcee. She had 1 kid at the age of 4 years old son, and we are not sure what's the status of her partner in the past. She denied any high risk behavior. She denied strongly on any drugs in the past. So in regards to the previous admission, she was admitted, first presented for the medical attention on the 16th of June, in which about a month before this current admission, she complained of severe headache. She went to GP and was given some analgesia. During that presentation, the GP took some renal profile, and the results is actually pending. After 2 weeks on analgesia, this patient was presented again to the same GP. So this time she complained of low-grade fever, and she was given an antibiotics. We are not sure what's the antibiotics, but it was a BD dosing for 6 days. During second visit to GP, the first renal profile taken on the first visit came back. So during that time, the creatinine already 167. She was advised for hospital referral, but she refused. So she was on antibiotics until a week later. She presented to another hospital complaining of persistent fever and severe headache. She was then admitted and was treated as pyelonephritis. According to her, during the admission, there is some imaging was done, no stones was noted. During that current admission, the creatinine raised up to 344. However, no acute dialysis was initiated. She was treated with IV cavarexim and discharged with oral augmentin until she presented again to us 10 days later with this presentation.
All right, Dr. Mina, so based on the additional information given to you by Dr. Yan, is it helpful?
Yes.
And then can you come out with certain things running in your mind in continuity to the initial question from Prof. Halim?
Okay, so based on what we have now, based on the further history as what she has been given antibiotics and also painkillers prior to this admission, and she has multiple hospital visits, and I think refused admission. At one point, she was also treated for pyelonephritis. However, no drainage, no any dialysis, and I think her kidney function was about 340 during her last visit at the hospital, the previous episode. No dialysis required at that time. So the provisional diagnosis at this point now, without having our further investigations, I think this patient this time around presented with nausea, vomiting, some vague symptoms, and malaise with a frothy urine. This patient probably has some acute kidney injury with a nephrotic syndrome, or has a renal impairment with a nephrotic syndrome. This could be likely due to a few reasons, whether the sepsis, a pyelonephritis, a recurrent pyelonephritis, or drug-induced because of the previous NSAIDs or any antibiotics that was given, acute interstitial nephritis, or acute tubular necrosis because of that. Yeah, these are my few provisional diagnoses. Could be because of hypovolemia as well. Pre-renal causes could be hypovolemic or septic.
All right. Do you agree that previous admission to other hospital is truly pyelonephritis? I didn't hear anything about having this, renal punch positive, because for the medical student, pyelonephritis, usually you have a renal punch positive.
It was just said that she had pyelonephritis, but not sure whether it was just an unresolving urinary tract infection at that time rather than a pyelonephritis. She should have been given a longer duration of antibiotics if it was pyelonephritis. She was discharged with oral antibiotics at that time.
Would a simple pyelonephritis causing worsening renal impairment?
No. Could be whether she had a renal abscess at that time, because could be a renal abscess or a renal tuberculosis. Could be, these are my few.
All right.
other things.
So your working diagnosis lies in the fact of infections.
Correct.
Right?
Yes.
Okay. Any other question from the floor? No.
Cause proteinuria.
Sorry?
Can lung infection cause proteinuria during the episode? A lot of people refer to nephro, when somebody develop bad lung infections and a bit of proteinuria, and sometimes nephro don't do anything. So I just want to ask you, can infection cause proteinuria?
Yes, can.
Yeah. What do we call that?
They have subnephrotic or nephrotic range proteinuria due to sepsis.
What condition we call it? We call it infection-related glomerulonephritis. It can be two. One
Yeah,
infection-related that during that time they develop proteinuria. There are some instances they develop proteinuria 2 weeks after that. That's why
Correct.
we call it
So post-streptococcal or a IgA, post-streptococcal
Yes.
glomerulonephritis or a IgA nephropathy. They can also have pulmonary involvement, whereby like vaginous or church straws, whereby they have pulmonary involvement, pulmonary infiltrates or pulmonary hemorrhage. Along with that, they have a glomerulonephritis as well.
All right. Good. You can move on.
So on this is the physical examination I think I mentioned just now. So just on further, is there any other positive findings on physical examination? I would like to ask Dr. Yan, what is the weight, height and a BMI? Why would I like to know that? Because the blood pressure when she came in to us this time around was about 90/60. Any evidence of icterus? Is she going through hemolysis? Is there any pallor, any oral ulcers, malar rash or vasculitic lesions? Any lower limb edema at this point of time? And on systemic examination, how was the cardiovascular examination, the apex beat, heart sounds, any additional heart sounds, murmurs? Abdominal examination, how was the renal punch at this point? Is there any pyelonephritis? These are the additional examination that I would like. And neurological examination, any evidence of any peripheral neuropathy, polyneuropathy for this patient, thinking in the line of whether if it is, what do you call that? Whether it's related to any polyangiitis or anything, RPGN.
All right. Before I ask Dr. Yan to answer all those questions, any additional questions from the floor? I'm a bit perplexed on the fact that you're asking about polyneuropathy. What are you thinking?
Polyneuropathy, you can present, I forgot that. Polyarthritis nodosa can present with polyneuropathy, along with that can have glomerulonephritis as well, along with joint pains.
All right. Anything else from the floor? Is there any questions? All right. Over to you, Dr. Yan.
Okay. She's a medium-built lady with a weight of 75 kilos with a height of 165 cm and with a BMI of 28. There is no jaundice, she looks pink, no oral ulcer, no malar rash and no other vasculitic lesion seen. There is no peripheral edema seen. On the system examination, nothing significant, the renal punch was negative, the cardiovascular examinations were perfectly normal, no murmur was heard. Neurological examination is actually intact.
She looks very beautiful. She's a beautician to start with, right? Quite fishy there, I believe, because Dr. Yan purposely give that kind of statement in the abstract. How she looks like, Dr. Yan? I'd like to know. The photo tak probably.
She's really a fair lady.
All right. Does it important to you, Dr. Mina, being a beautician? Because Dr. Yan give that history in the abstract.
She'll have easy access to beauty supplements, herbal products, and what kind of what does she do as a beautician?
All right.
Any spa, any massage, because I would like to know any high risk behavior and all that as well in her STD related.
Is some sort of judgmental over here. Should not, but we do understand that certain work or job carries certain risks. For pulmonary disease, we have certain risks, you know. For some neurological tremor whatsoever, certain disease. For nephro, certain disease. For cardio, certain disease. But I think in relation to that, we have to understand for undergrad that certain risk factors should be explored. All right. So, is it helpful? Dr. Yang says almost nothing.
Okay.
All right. Move on.
Okay, so this is the laboratory investigations that I have. This is the limited information that I was given. The hemoglobin is 9.3, so she's anemic with a platelet that is normal 459. Total white is 12. Sodium is 133. She's hyponatremic. Potassium is also low, 3.3. Urea is 21.5 with a creatinine of 579. Her last one was 344 prior to this. Albumin is also low, is 34. Blood gases that I have, pH is 7.29 with a bicarb of 18.9. There's evidence of acidosis, but I do not have the further PCO2 here to calculate. Urine FEME, protein is 1 plus, so she does have some proteinuria with blood 1 plus, RBC 1 plus, nitrate negative. Urine PCI is 0.11, so she has some subnephrotic range proteinuria. So based on this, we can see that she's anemic and she has some renal impairment here with probable metabolic acidosis and a subnephrotic range proteinuria with minimal hematuria as well.
All right, hold on. So can you tell me more about the renal profile? I mean, is it common for someone who has worsening renal function to have a hypokalemia and hyponatremia there?
The hypokalemia and hyponatremia could be because of her electrolyte imbalance. She had episodes of vomiting prior to this presentation, but however, it's not common that patient presenting with acute kidney injury, they usually may present with hyperkalemia rather than a hypokalemia.
So if this patient had significant GIT loss, so what do you expect in terms of blood gases? Should it be a metabolic acidosis or the other way around?
Metabolic alkalosis. Yeah.
So how do you tie up all of this?
So she has a metabolic acidosis. I'm not sure about the anion gap, but it could be because of the metabolic acidosis could be because of a sepsis or could be because of an ongoing sepsis along with that or a hyperlactatemia or could be because of the salicylates, NSAIDs that she has been taking could also cause the acidosis rather than the episodes of vomiting by itself.
So what else that you would like to ask from Dr. Yan?
I would like to ask the PCO2. To measure the Winter's formula and also the sodium, potassium and the chloride for this patient.
You're going to ask for anion gap, right?
Yeah, anion gap, correct.
Have the information, Dr. Yan?
Yes, the anion gap is high.
All right, so for medical student, every time that you have a blood gases, it should be interpreted beyond the value given to you, especially try to understand the anion gap. All right? What else I can? Do you think the HB 9.3 consistent with which type of thalassemia that you are aware of? Is it a major one? Minor one?
Thalassemia minor.
Right. All right. Maybe thalassemia history is not that significant in this case. I don't know.
Yeah.
All right. So someone with creatinine of 579, severe to me, renal impairment. What other complications might have happened to this patient that you want to know? Besides the acid base, electrolytes, anything else?
Fluid balance.
Dr. Yan did mention it's not overloaded, no edema, not using any oxygen. Anything else in your physical examination or bedside monitoring?
Any pleural effusion, pericardial effusion?
Sounds clear given to you. Anything else important? What are the which kidney producing?
Uremic fetal, patient's breathing.
All right. Anything
rapid
else?
Breathing.
Kidney produce apa? As a assessment of renal impairment, two parameters you're looking at, creatinine and
Urea.
AKI for acute kidney. If this is acute kidney injury, I believe it's so.
Urine output.
All right. Do you want to know how much the urine output in the? All right. Okay. So that's a very important, simple question that you should ask. If a patient came to you with reduced urine output, laboratory parameters should be checked. It could be because of hypovolemic, then kidney try to preserve the volume by not producing urine output, like for us in fasting months. Or it could be truly shutdown of the kidney functions. They cannot produce, then metabolic complication going to start happen. All right. So Dr. Yan, is there anything else you want to ask for the question? To Dr. Yan?
Just the blood gases, the NIN gap she's answered. I think it's the urine output that I do not have.
On presentation, the urine output is about 600 over 8 hours.
So what does that mean to you? She's how many kilos just now, Dr. Yan?
75 kilos.
All right. Does it help?
She's not oliguric, based on 0.5 ml per kg per body weight, less than that. She's over 6 hours, her urine output is normal. She's not oliguric at this point of time of our presentation.
All right, move on.
Okay, so the further investigations that I would like to ask Dr. Yan, at this time, the serial renal functions that we have, the serial blood gases, full blood picture, iron studies. Okay, the reason I was asking for this evidence of hemolysis was whether because patient is thalassemic, but I think the thalassemia at this point of time, she's not transfusion dependent, most likely thalassemia minor may not be relevant. More of the full blood picture, iron studies, eosinophil count, to know whether, because if patient has got acute interstitial nephritis, she may have eosinophiluria, and also the ESR, CRP, and the blood cultures taken, viral screening for this patient. The others will be a urine culture and also urine phase contrast microscopy.
Okay, Dr. Mina, this is a serial investigation available during this admission. So as mentioned, when she first presented to GP, he had a baseline creatinine of 177. So after 2 weeks of treatment, then the creatinine jumped up to 344. On arrival to us, the creatinine was 579 with a urea of 21.5. If you notice that from 24 until 29, some intervention was done in the ward, and subsequently the creatinine was static around 380 to 440.
Okay, Dr. Mina, moving back to the physical examination that was given to you, blood pressure of 90-ish, right? On the 24th, Dr. Yan gave you this kind of urea and creatinine. Can you tell me more? Is it a proportionate or disproportionate value?
No, it's disproportionate. No, it's proportionate, yes. It is proportionate.
What do you mean by that?
Proportionate, the urea times 20 should, if it's more than your, if it's more than the expected, then you're thinking whether it's a disproportionate urea creatinine, and then you're thinking of dehydration or something causing her to have this disproportionate urea.
All right. May you give a guess to what kind of management that was given by Dr. Yan in the ward? Because creatinine came down from 500, almost 600 to 300, 50% reduction.
Probably hydration, ensuring hemodynamic stability for this patient. Unsure whether it's just volume based or whether inotropic supports were given for this patient. And then if there was evidence of infection, probably some antibiotics has been given as well.
All right. So essentially, you're thinking what type of AKI? Pre-renal, renal, or post-renal over here?
Okay, this one could be a pre-renal or a renal AKI. I think pre-renal because the hypovolemia as such, or a sepsis. Renal, the reasons being it could be it also could be a glomerulonephritis that we are actually dealing with at this point of time because of the rapid increase in the urea creatinine from June until July. So probably we have got to investigate the causes for her pre-renal and her renal.
So essentially, you do agree this patient has some pre-renal component, but you cannot totally eliminate component of renal AKI. Medical student, you must understand the moment you talk about AKI must be pre-renal and post-renal. All right, move on.
Other investigation as requested, the blood culture, urine culture was no growth. Urine phase contrast was isomorphic, while the virus screening was non-reactive. The CRP is 4.2 with the ESR of 105. As requested, since the HB is 9.3, the iron study shown T-set of 23 and ferritin of 542. The autoimmune screening was done. The ANA is 1 in 100 with speckle and cytoplasmic with negative of dsDNA. C3, C4 is normal, Cum test is negative, and other hemolytic screening as mentioned. LDH is 125, retic count of 1.5, and also bilirubin is 1.7. Dr. Mina, you're requesting for MPO and a PR3 antibody and anti-GBM. However, this investigation was not sent.
So based on what I have now, the urine phase contrast is isomorphic. I was actually looking for any dysmorphic RBC in the event of glomerulonephritis. The viral screening is non-reactive. A CRP, so CRP is slightly raised. ESR is high. It's 105. It could be due to many reasons. Sepsis, any inflammation, and this may actually might make us think of probable renal tuberculosis, but however, she does not have any previous lung symptoms to suggest, and we do not have a MEN2 for her now. Transferrin saturation is 23, which is normal, more than 20%. If you're thinking of iron deficiency, but and the ferritin is 542. So this is high. Anti-nuclear antibody is 1 in 100. This is non-specific because she does not have other symptoms to suggest that she has SLE at this point of time. C3, C4 is also normal, and she is not hemolyzing. Yeah.
Can you tie down your working diagnosis now? If I were to ask you, give 2 in your list?
My 2 in my list will still be acute kidney injury with subnephrotic range proteinuria, likely secondary to acute interstitial nephritis, acute tubular necrosis, or probably I'll also add a renal tuberculosis.
All right. So why you are thinking about acute interstitial nephritis, is it?
Yeah.
What is there to support acute interstitial nephritis?
Here, I do not have anything to support acute interstitial nephritis. My urine, I'm not sure if I did not ask for any white blood cell cast or any eosinophil urea. It's just based on the history that is that it could be suggestive, but my urine analysis does not confirm my diagnosis of AIN. So I would like to further investigate.
So you want to ask about urine eosinophil, is it?
Yes.
Is there any, Dr. Yan?
No, there is no eosinophils in the urine. Might as well any cast detected.
All right. So,
however, the eosinophil counts was 0.7.
All right. So you asked for peripheral blood films, right?
Yes.
So for the peripheral blood films, I would like to invite from Patho Department, Dr. Nur Azan. Is she here? Oh, there. Okay. So please, Azan, hopefully that you can ask Mina to interpret first the peripheral blood film before you are telling us about any abnormalities.
Thank you, Prof. So this is the FBC indices that was given during the that we analyzed from the FBP sample sent to our unit. This shows HB of 7.6, which is moderate anemia. MCV is 67 and MCH is 20.5. It is quite severe hypochromic microcytic indices. However, the red cell count is low, 3.7. And then the white cell is leukocytosis, 11, with differential count of myelolymphocytosis, 3.4, and also myeosinophilia with a reading of 0.8. The platelet is normal in count, 354. Otherwise, from these indices, we can see the nucleated red blood cells is 0 detected by the analyzer, and the immature grants is only 0.6. So this is the full blood picture in low power view. Oh, okay.
So this is the full blood picture of the patient. There's N-isopoikilocytosis, whereby there's different sizes of the red cells. There's a microcytic hypochromic cell seen. Along with that, I think there's also some pencil-like cells here, which I think probably this is due to iron deficiency anemia. Otherwise, we see some platelets here, which looks quite normal, and a neutrophil here. cannot appreciate any eosinophils or anything in this picture. Thank you.
Okay, I try to explain further. So basically, what we done when we receive the full blood picture is we correlate the indices along with the smear. So here, what we can see, here is the red cells, like this. And then this is the activated lymphocyte. And then this is the grants or neutrophil. So basically, from this picture, at low power view, we can see dimorphic picture. What is dimorphic picture? It is mixture of normochromic normocytic red cell, like this, with hypochromic microcytic red cell. The central pallor is more than 1/3 of the red cell. So, also we can see the tiny dots like this is the platelet. Alright, so we go to the next picture. Here we can see some platelet agglutination. You can see, right? And also the neutrophils. The neutrophils looks healthy without any toxic granulation or cytoplasmic vacuolation. Okay, more higher power. Here we can see some teardrop cells and also elliptocytes, pencil, activated lymphocyte. The grants looks healthy. Like this, it is not hypersegmented. What is hypersegmented neutrophil? The lobes should be more than 5, but here is only 1, 2, 3, 4. More higher power, elliptocytes, like this, hypochromic microcytic red cell, but this one is normal. You can see the difference, right? It is more than 1/3. This is normal. Okay, teardrop cells and elliptocytes. This is our platelet lah, healthy looking with previous picture showing some agglutinations that we can normally see in case of infections or any inflammation. Otherwise, in FBP, usually when the count is normal, that we can see in this patient, it is 300 plus, we don't comment lah the platelet agglutinations. Unless it is thrombocytopenia, then we comment because the platelet agglutination can contribute to pseudothrombocytopenia. That is the falsely count platelet by the analyzer because of the platelet clumping. All right. This picture shows more. Where is the cursor? More clear picture of here target cells and also elliptocytes, target cells also. So target cells we can see in condition where there is iron deficiency or any hemoglobinopathy or thalassemia trait. The anisopoikilocytosis. What is anisopoikilocytosis? It is different size and shapes of the red cells. It's not so severe. It is mild anisopoikilocytosis. So mild anisopoikilocytosis give us hint. It is could be only thalassemia trait or it is mild iron deficiency. Activated lymphocyte. Usually the normal lymphocyte will look more smaller and it is not like this. This is activated lymphocyte here, clearer picture of elliptocyte and also pencils. Alright, from this picture we can see quite increased amount of eosinophils. Can see here the cells that having spectacle wearing person here with the cytoplasmic is quite pinkish with lots of granules. Here another eosinophil, and here another one. This is the normal lymphocyte. Okay, normal grants. Okay, what is this cell? This is immature granulocyte or we also call as myelocyte. So from this FBP we can conclude that there is immature form of granulocyte indicating presence of left shift of this patient. So left shift signifies patient is ongoing infection or inflammation. Another picture showing myelocyte.
All right. Thank you, Dr. Azan. So we have someone with eosinophilia plus some evidence to suggest ongoing infections or inflammations. Okay, I hope that helps Dr. Mina. Thank you, Dr. Azan. So let's move on for interest of time. Anything else that you'd like to ask, Dr. Mina?
Okay, yeah. So we are done with the laboratory investigations and also urine. I would like to request for further imaging, a chest X-ray and an ultrasound KUB for this patient.
What do you want to look for from the chest X-ray?
Okay, from the chest X-ray, if I'm actually thinking of any infection, I would like to look for any pulmonary infiltrates, any opacities to suggest any infection or a pulmonary hemorrhage as such, or any cavitation if I'm thinking of a tuberculosis. On the ultrasound KUB, what I would like to look for is any evidence of pyelonephritis or any renal calculi, any obstruction, any hydronephrosis for this patient.
All right. With that, I would like to invite Dr. Imree from the Radiology Department to assist on that question.
Okay, good morning, everyone. Thank you for the invitation. So patient had 3 imaging modalities which we did, X-ray, ultrasound, and also CT. So this is the chest X-ray. It is normal. All right. And also you can see the lungs, there's no opacities, no consolidation, no cavities, or no miliary nodules to suggest any active infection, no pleural effusion. And this is the KUB X-ray. Do you want to comment anything on the KUB X-ray?
I do not see any obvious stones. It looks fairly normal.
You are correct, Dr. Mina. So X-ray KUB, in terms of investigating for renal urinary tract infection or disease, you want to see any hyperdensities along the urinary tract to see evidence of stone, and also grossly look at the kidneys to see if there's any gas surrounding the kidneys which could suggest emphysematous pyelonephritis. So here are the outline of the kidneys, the right and left kidneys. Subsequently, patient had ultrasound to look for any evidence of obstruction, hydronephrosis, or with a clinical picture at that time, they were worried about pyelonephritis. So this is the right kidney. The right kidney, it has a normal size and configuration. The outline is normal, smooth and regular, normal vascularity. However, there's a bit prominence in the renal pelvis over here. Same goes to the left kidney. It is normal with minimal prominence in the renal pelvis. So we concluded that patient had bilateral minimal or mild hydronephrosis. And the good thing about ultrasound is that it's a quick examination, easily accessible and radiation free. However, the downside is that when you have an obstruction, it will be difficult to determine the level of obstruction, especially in the abdomen because of the bowel gas. So naturally, you would proceed with CT. So here is the CT. So it's a movie and you are seeing it as if you're scrolling from craniocaudally, in other words, from top to bottom. All right, do you see any stone in the urinary tract? No? Okay, correct. So this CT or CTU, this is a non-contrasted CT. So we have a look at the region of interest. So here, basic anatomy, this is the liver, the spleen, and then at the level of T12, you can see the kidneys. So here are the kidneys, the right kidney and the left kidney. If you can see here, because we saw mild hydronephrosis on ultrasound, you pay close attention to the renal pelvis, which in fact was not dilated. It is normal. And also looking at the ureter, there's no stone in the ureter. And there was also no stone in the kidneys. And as we go along at the urinary tract, ureters, no hydroureter. And this is the urinary bladder, which is moderately distended with smooth regular outline. So kidneys are retroperitoneal organ and they are bounded by the fascia and also fat. So any inflammation, infection, tumor or even trauma can disrupt the fat and also the fascia. So when we're looking at any renal pathologies, we also look at the surrounding of the kidneys to see if there's any fat stranding or fat stickiness, or what we call perinephric fat stranding. And also look at the fascia if there's any thickening. This is just another view in axial, coronal, and sagittal view of the CT, just to show the kidney themselves are normal, no hydronephrosis, and the perinephric fat was in fact clear. So since we talk about, in conclusion, this was a normal CTU. Not interesting, but important nonetheless, because there's no obstruction, no hydronephrosis, no renal collection or intra-abdominal collection. So the only abdominality that we found initially was hydronephrosis. So do you know how many categories of hydronephrosis we have? We have mild, moderate, and severe. So unlike pediatric age group, they are quite comprehensive. They have specific measurement because they usually routinely scan and also follow up their patient using ultrasound instead of CT because of the radiation. But in adult patient, they are more subjective. So mild hydronephrosis, there's only dilatation of the renal pelvis. Moderate hydronephrosis, dilatation of the renal pelvis and calyces. And in severe hydronephrosis, there is dilatation of the renal pelvis, calyces, and parenchyma thinning. So here are examples of different degrees of hydronephrosis. So on your left-hand side is mild hydronephrosis, which is dilatation of the renal pelvis. In the middle, you can see dilatation of the renal pelvis and also blunting of the calyces. And your most right side is, if you see, there is slight thinning of the renal parenchyma compared to the middle one. So this is the severe hydronephrosis. And also here you can see the perinephric fat stranding is more prominent compared to the rest. And also there's thickening of the Zucker-Kendall fascia over here.
All right, thank you so much, Dr. Imree. Pretty much juicy and beautiful structurally kidneys, but not functionally. Yeah? All right. What's next, Dr. Mina? Not helpful.
Renal biopsy.
All right. Okay. So you really wanted renal biopsy. What is your working diagnosis now? Professional, at least. Next slide, I think. Yeah. Slideshow.
Okay. Yeah, so my provisional diagnosis, again, so we have removed renal tuberculosis. It's acute interstitial, my provisional diagnosis, acute interstitial nephritis, secondary to possible drug-induced, or an acute tubular necrosis, secondary to sepsis or ischemia or drug-induced. My other differential diagnosis, pre-renal, as I said, hypovolemia or sepsis. Renal glomerulonephritis, pyelonephritis is removed. Post-renal obstruction, there is no evidence of obstruction as well.
So now your working diagnosis is acute interstitial nephritis. The kidney itself is the culprit.
Correct.
So you're going to proceed for renal biopsy?
Yes.
All right. So you want the renal biopsy report. Okay,
Yes.
with that, I'd like to invite Dr. Razin, panjang nama dia tapi saya panggil Razin saja, to elaborate further on the renal histopathology. Maybe cepat Razin, we have 10 minutes to go. Okay. Okay, Assalamualaikum and a very good morning. So I'm from pathology. So basically, for the renal biopsy, we have these two cores of renal cortical tissue, and it contains up to 12 glomeruli. So from the picture here, this is the two renal cortical tissue from low power. We have this one sclerosed glomeruli, and the rest of the glomeruli are normals. So this is another picture showing the normal histology of the renal nephron, part of the renal nephron. As you can see, this is the glomerulus, composed of the capillary tuft with its Bowman space, and then the interstitium. In this picture, we have these convoluted tubules, the distal and also the proximal tubules. Okay, so this is one of the closer image of the glomerulus that we have. Dr. Mina, can you see or comment on the glomerulus we have here?
Okay, so this is the glomerulus that we have here.
Normal, abnormal?
It looks abnormal. I think there is a global sclerosis.
All right. All right, you are correct, Dr. Mino. This is glomeruli sclerosed glomerulus that we have. Okay, and then it's actually about 1 out of 12 glomeruli are glomeruli sclerosed. So it is around 8.3% of the global sclerosis. So for the acceptable global sclerosis, we have this formula, which is age divided by 2 minus 10. So in this patient is a 38 years old female, so around 9%. So it is still acceptable in this patient. So the rest of the glomeruli are normal. Okay. So this is the interstitium, which are expanded by severe mixed inflammatory cell infiltration. This is the normal histology of the kidney, which shows the tubules which are back to back. It is normal, back to back tubules. However, in this case, we see that the tubules are widely separated, and between the tubules are severe mixed inflammatory cells. So this is the higher power of the interstitium. Okay, this is a normal histology again. The tubules are lined by epithelial cells, and then the nuclei is small. But then, however, in these patients, we can see that the tubules are lined by epithelial cells, which have enlarged nuclei. Okay, and there is also this prominent nucleoli, and also occasional mitosis. All these changes are actually reactive changes that happening in the kidney of the patient. Okay, so this is higher power of the interstitium. The infiltration composed of lymphocyte. Okay, this is actually the lymphocyte. Okay, plasma cell. This is a plasma cell which has this eccentrically located nuclei. Neutrophils with a few lobation of the nuclei, and also there are occasional eosinophils. Okay, this is the eosinophil. Maybe the picture here is not really obvious, but then these are the cells that constitute the interstitium. No microabscess formation are noted, and also there is no granuloma formation seen. Okay, so this is one of the tubules that we have, and then within the tubules, actually we can appreciate there are white cell casts inside the tubules. However, it is very focal, and then there is no significant tubular atrophy. So for the vessels, there is no internal thickening, hyalinosis or vasculitis seen on the vessels. So all these are showing the vessels on a different stain. Immunofluorescence study, there is no glomerulus included, and there is no immune deposit observed within the tubules. So for interpretation, okay, so renal biopsy we conclude it's an acute tubular interstitial injury, and then there is a severe tubular interstitial injury and inflammation with presence of eosinophils. Only focal white cell casts within tubules, no microabscesses. So overall features are suspicious of acute tubular interstitial nephritis
ATIN with background or consistent with history or pyelonephritis. So that's all from.
Thank you so much, Dr. Anissa. And within 5 seconds, Dr. Mina, what is your final diagnosis now?
Okay. I think this patient, this young 34 years old, I think she has got an acute kidney injury with a subnephrotic range proteinuria, secondary to acute tubulointerstitial nephritis due to possible drug or pyelonephritis, the history of pyelonephritis that she had.
All right. So you think you have eliminated glomerulonephritis,
Yes.
essentially, but the problem lies in the fact of the interstitial, right?
Yes.
So the final diagnosis is acute tubulointerstitial nephritis. This is not a diagnosis; it's a problem. Yeah, there are many factors contributed to that. Okay, thank you so much, Dr. Mina, for your kind presentation. I would like to invite Dr. Yan within 5 minutes to wrap up, tell us what happened to the patients, and quickly elaborate about ATIN.
All right. Thank you, Prof. Ruslinda, and the rest of the audience. Please bear with me for the next 5 minutes. I will go fast. All right. Finally, the primary diagnosis for this patient is actually acute tubulointerstitial nephritis. So, before we go further, let's recap on the definition of the kidney disease. So, definition of AKI is an abrupt reduction of the renal function that occurring within 7 days and less. However, CKD is defined as persistent kidney impairment, persistent kidney disease for the period of more than 90 days. Between these two clinical entities, there is a transition status, which is named acute kidney disease, which is AKD. It is described as an acute and a subacute damage or loss of the kidney function in duration between 7 to 90 days after the exposure to the initial AKI insult. So based on the clinical observation, recovery from the AKI within 48 hours after the initiation of the event initially heralds rapid recovery of the AKI. However, for the patient with a pre-existing CKD, the AKI event also can be superimposed on the CKD, and with the AKD existing on the background of the CKD, it shows a high risk of the kidney progression and the future development of the end-stage renal failure. So once AKI been encountered, the insult frequently leads to the subsequent chronic kidney disease progression despite of temporary recovery of the AKI. So what is acute tubulointerstitial nephritis? Acute tubulointerstitial nephritis is a very common cause of AKI, but the true incidence might be even underestimated by several reasons. So this diagnosis is actually a histopathological diagnosis characterized by inflammatory infiltrates in the kidney interstitium, typically causing AKI. So this interstitial inflammation can lead to chronic changes and later development of the CKD. The global prevalence of the acute interstitial nephritis is about 1 to 3% among all the renal biopsies. However, in the overall prevalence of the acute interstitial nephritis was increased among those who are with AKI and been biopsied. So clinical diagnosis is, for the acute interstitial nephritis is very challenging. From the case illustrated, there is non-significant specific symptoms or sign being on presentation. So this patient might present with a renal manifestation, or this patient might present with systemic manifestation. Even so, from the traditional clinical triads of AIN for a fever, rash, eosinophilia, only 7% for the general population presented with this typical clinical triad. Renal failure is slowly progressing. Most of the literature reported as only half will presented with a severe AKI. And in this diagnosing of acute interstitial nephritis, there is no diagnostic blood, urine, or imaging test. If you see, all the investigation been sent is actually is not conclusive. Even you have urine eosinophil, you are looking hard for the urinary cast, even the urinary FME, none of this is actually shown a highly specificity or sensitivity. Thus, in the absence of these non-invasive biomarkers, renal biopsy is actually a gold standard for the diagnosis. let's look through the presentation and the clinical laboratory features at the presentation of the acute interstitial nephritis. Most of them typically presented with the renal manifestation. They may presented with the acute kidney injury totally, all right, and they might have non-nephrotic proteinuria, leukocyturia, or even microhematuria. And more rare renal manifestation, they might have gross hematuria, nephrotic range proteinuria, and even complete nephrotic syndrome. However, they also presented with other systemic manifestation as such as fever, eosinophila, skin rash. So let's get through into the etiology of the acute interstitial nephritis. So, infection and also autoimmune still carries a contributor for this etiology. However, drugs is the main contributor for this entity. If you look through the epidemiology of evolution of acute interstitial nephritis, in the past, the disease was first prescribed in 1988, mainly associated with the infection disease. However, during the change of 20th century, when the drug-induced AIN started to be relevant, the current assuming of incidence of drug-induced AIN is more than 75%. So what is drug-induced AIN? Is the third common cause of AKI in hospitalized patients, and overall percentage of biopsy meeting the diagnosis of AIN is increased from 3.6 to 10.5, especially in elderly. I believe this is because of the generalized use of antibiotics and even the over-the-counter drugs, especially NSAIDs, and also the PPI, and knowing the population with the chronic medical illness with the multiple medications, and the fact that the lower threshold for the biopsy nowadays. So the pathogenesis was postulated as a type 4 idiosyncratic delayed hypersensitivity reaction mediated by T cells. This evidence supported by the eosinophils was commonly found in the renal biopsy, and also the T cells are found to be dominant in the as a dominant lymphocytes. And also the symptoms remain for those of systemic hypersensitivity reaction, and even on the IF, immunofluorescence from the kidney biopsy is actually negative for immunoglobulin and also the complement that fever altogether is actually type 4 hypersensitive reaction. So if you look through at this long list of medication that can cause acute kidney injury, acute tubular interstitial nephritis, all drugs can cause acute interstitial nephritis. But to bear in mind, the long list belongs to this antimicrobial agent in which we are commonly and regularly uses in our daily clinical practice. So followed by NSAID and even anticonvulsion, PPI, and our lovely drugs is actually furosemide. So looking at other medication, it's actually allopurinol, our lipids lowering drugs as such of fenofibrates, antihypertension, captopril, propanolol, anti-thyroids, also PTU, and even anti-cancers also can cause all these the incidence of acute tubular interstitial nephritis. Let's see through what is the top 3 drugs that have been reported to be to cause the acute interstitial nephritis, which is antibiotics, PPI that we prescribe as water in the ward, and also NSAID. So as I mentioned, all drugs can cause acute interstitial nephritis, and this is not a dose dependent. This is an exposure dependent, and recurrence might be happen on the second exposure. So if you look into what antibiotic can cause, basically the most reported one is actually beta-lactams group, followed by rifampicin, vancomycin, all generations of the cephalosporin, quinolones, especially ciprofloxacin, and also sulfonamide. So even with our prescribed medication, there is a few other case reports that reported that other dietary supplements, herbals, and also additional supplementary can cause acute interstitial nephritis. Here, let's as basis is please get a thorough history from your patient, especially on the drug history. So how to manage this patient? definitely we have to stop the offending drugs, all right, and continue all the supporting treatments. We might consider monitoring and continue look and observe until 3 to 5 days. If no response, then we had to think of what's next, and the kidney biopsy must be performed to confirm the diagnosis after excluding any other causes of acute renal failure. So, if all the confounding factors been treated and there is no contraindication for the treatment of steroids, then steroids must be commenced. So, the aim of the treatment is actually to halt the progression of CKD while monitoring of the therapy complication. So why steroids? Right, there is a few literature that comparing between steroids and non-steroids group in treating acute interstitial nephritis. Basically, steroid group is better in terms of the dependent of the dialysis, might as well the recovery of the kidney disease. And what steroid should we give is either high dose metoprolol pulse or even oral steroids. However, there is no significant difference between these two regimes. You can give your oral steroid or you can even pulse the patient with the IV metoprolol. And how long should we give? All right, there is no consensus. Even so, even a short period of administration of steroids or even after 8 weeks of the steroids is actually associated with a greater kidney function recovery. So back to our patient. This patient before presented to us, she's already had AKD because the presentation is more than a week. So she presented to us at weeks 5 and with a creatinine initially of 527, and after a week in the ward, there is no recovery at all after all the supportive management, and we decided to embark this patient on oral corticosteroids, which is 1 milligram per kilo per day. So upon initiation of the creatinine, upon initiation of the steroid is a creatinine of 467, and we discharge and we monitor this patient as outpatient. So she came back to us after a month, look through the creatinine now normalized to 93, and the steroid starts to taper off. So after 2 weeks of the treatment, she had a complete resolution of the kidney function, and the treatment can be stopped. So, ladies and gentlemen, drug-induced AIN is a common entity in the clinical practice, provided this is, however, this is remain a challenge for the clinician as a weakness and even the absence of the definitive clinical symptoms. So high clinical suspicion is needed. So renal biopsy is still perceived as a gold standard approach, and even so far, the optimal treatment for this entity is not well recognized since there is no clinical trial to provide the highest level of evidence. However, the fundamental pillars of the treatment are still withdrawal of offending drugs, and the administration of the corticosteroids can hasten the recovery and halt the CKD progression. With this, I thank you.
All right, thank you very much, Dr. Yan. I believe acute tubular intestinal nephritis not uncommon, but it's a diagnosis of exclusions on its own. So when you try to prescribe any medications, so just be careful, those unnecessary drugs do not prescribe, right? Because the effect is obvious to the kidneys and have very high index of clinical suspicions. All right, with that, we are beyond time. So I would like to thank all the speakers for your beautiful discussions today from radio, patho, all right, and internal medicine. And please thanks them in usual manner again. All right, for the medical student, we have a quizzy, right? And Dr. Yan have one present for you for the best person who can answer those questions. Over to you, Cik Bukhari. Thank you very much to those who attend to today's species. Have a nice day. Wishing you all the best.